Welcome to MedMentor Prep. We truly hope you find this videos useful in your learning journey. I'm your host, Dr. Hassan Suddi. Please remember, the information presented in these videos reflects my personal notes and insights. It is not intended for the management of your patients. Always consult a qualified healthcare professional for specific medical advice or treatment.
Systemic sclerosis.
Systemic sclerosis is a chronic autoimmune connective tissue disease characterized by fibrosis, vasculopathy, and autoimmunity, affecting skin, joints, GI tract, lungs, heart, and kidneys.
Types.
Types of systemic sclerosis. The rationale behind the division is the difference in the disease course, severity of organ involvement, and the autoantibodies. The first type is the limited cutaneous systemic sclerosis. Skin involvement distal to elbows and knees, often anticentromere antibody positive. Disease has a slower progression. The other type is the diffuse cutaneous systemic sclerosis. Involves trunk and proximal limbs, early organ involvement, associated with anti-SCL70 or anti-RNA polymerase III. Please note that both types can involve the face and the neck.
Clinical presentation.
In this segment, we will discuss the involvement of various organ systems, including the skin and the Raynaud's phenomenon, the musculoskeletal system, the pulmonary system, the heart, the gastrointestinal tract, and the kidneys. Let's begin our discussion on skin involvement, which can present in several noticeable ways. Firstly, one of the early manifestations is puffy hands. This is typically caused by inflammation and may lead to a noticeable change in appearance. Another common symptom is skin itching. One of the hallmark features of systemic sclerosis is skin thickening, particularly in the fingers, known as sclerodactyly. In this condition, skin becomes tight and waxy, leading to stiffness and reduced mobility in the fingers. This thickening may spread other areas, making movement increasingly difficult. Patients may also experience changes in skin pigmentation, resulting in hypopigmentation or hyperpigmentation, often described as a salt and pepper appearance. This can cause uneven skin color and may have implications for a patient's self-esteem and social interactions. Additionally, lipoatrophy can occur, which refers to a localized loss of fat beneath the skin. This can create noticeable indentations, particularly in areas where fat loss is significant, affecting the overall contour and appearance of the skin. Another important manifestation is calcinosis. This condition leads to the formation of small calcium deposits in the skin, which can present as hard lumps or nodules. These deposits can become painful and may require medical treatment, depending on their size and location. Finally, telangiectasia, which are small, dilated blood vessels just beneath the skin surface. These can appear as tiny red or purple streaks, most commonly on the face, neck, and hands. While often harmless, their appearance can be concerning for patients and may prompt discussions about cosmetic options. The musculoskeletal system often manifests as arthralgia and, potentially, arthritis impacting daily function. Another distinctive sign is tendon friction rubs, which indicate underlying tissue changes. The cardiac complications include pericarditis, presenting with chest pain. Arrhythmias may arise due to structural heart changes, leading to palpitations. Additionally, fibrosis of the heart muscle can cause heart failure. Regular assessments are crucial for optimal management of these complications and to improve patient outcomes. Pulmonary involvement in systemic sclerosis. In this section, we will explore the pulmonary manifestations of systemic sclerosis, particularly focusing on two significant conditions: interstitial lung disease, ILD, and pulmonary arterial hypertension, PAH. Interstitial lung disease, ILD, is one of the most common pulmonary complications related to systemic sclerosis. Early detection of ILD is crucial, as it can significantly impact the prognosis. Patients often present with symptoms such as a dry cough and progressive dyspnea. According to the latest EULAR/BSR guidelines, routine screening for ILD is recommended, typically through pulmonary function tests and high-resolution CT scans. These imaging studies are vital for detecting the characteristic patterns of lung involvement, such as ground glass opacities and reticular patterns indicative of fibrosis. Once diagnosed, managing ILD may involve immunosuppressive therapies, including agents like mycophenolate mofetil or cyclophosphamide, as well as supportive care aimed at optimizing lung function and improving quality of life. Moving on to pulmonary arterial hypertension, PAH. This condition is another serious complication of systemic sclerosis that can develop in approximately 10 to 15% of cases. PAH is characterized by elevated blood pressure in the pulmonary arteries, which can lead to right heart failure if left untreated. Patients may experience symptoms like exertional dyspnea, fatigue, and chest pain. The EULAR/BSR guidelines emphasize the importance of early identification of PAH. Screening typically includes echocardiography and, when indicated, right heart catheterization to confirm the diagnosis. Treatment aimed to lower pulmonary artery pressure and improve exercise capacity and overall prognosis. A gastrointestinal involvement in systemic sclerosis. In systemic sclerosis, gastrointestinal manifestations are quite common and can significantly affect patients' quality of life. One of the primary symptoms is dysphagia, or difficulty swallowing. This occurs due to esophageal motility disorders, which lead to altered peristalsis and decreased esophageal contractions, resulting in a sensation of food being stuck. Another frequent complication is gastroesophageal reflux, GERD. As lower esophageal sphincter tone may be impaired, patients might experience heartburn, regurgitation, or chest pain, necessitating lifestyle modifications and, often, proton pump inhibitors to manage symptoms effectively. Many patients also report bloating and malabsorption, which stem from intestinal dysmotility and reduced digestive function. This can lead to abdominal discomfort and nutritional deficiencies. The latest guidelines emphasize the importance of nutritional assessment. Turning to renal involvement, one of the most serious complications is scleroderma renal crisis. This condition is characterized by a sudden onset of severe hypertension and acute renal failure. Early recognition and management are crucial to prevent irreversible kidney damage. Treatment typically involves aggressive blood pressure control, often utilizing ACE inhibitors, which have been shown to improve outcomes in affected patients.
Workup.
Blood workup are 1. Autoantibody testing, which includes anticentromere antibodies, positive in the limited scleroderma, anti-SCL70 antibodies, topoisomerase I, which is associated with the diffuse type, anti-RNA polymerase III antibodies, linked to a higher risk of renal crisis and malignancy. 2. Complete blood count, to assess for anemia or leukopenia. 3. Renal function tests, to monitor for renal involvement. 4. Liver function tests. 5. Inflammatory markers, such as C-reactive protein or ESR, to assess for systemic inflammation. Imaging workup. 1. High-resolution CT scan of the chest, to evaluate for interstitial lung disease and pulmonary fibrosis. 2. Echocardiography, to screen for pulmonary arterial hypertension and assess cardiac function. 3. Nailfold capillaroscopy, to assess for capillaries abnormalities, and this will help to differentiate between the primary Raynaud's disease and the Raynaud's phenomena secondary to systemic sclerosis. 4. Ultrasound may be used for assessing organ involvement, particularly the kidneys.
Treatment.
1. Raynaud's phenomenon. Dihydropyridine-type calcium antagonists, usually oral nifedipine, should be used as first-line therapy. Intravenous iloprost should be considered for severe cases following failure of oral therapy. 2. Digital ulcers. Phosphodiesterase inhibitors and/or intravenous iloprost should be considered for the treatment of digital ulcers. Bosentan should be considered for the reduction of new digital ulcers. 3. Pulmonary arterial hypertension. Combination of phosphodiesterase inhibitors and endothelin receptor antagonists should be considered as first-line treatment. Intravenous epoprostenol should be considered for the treatment of systemic sclerosis patients with advanced PAH, class 3 and 4. Riociguat can be considered for treatment. 4. Renal crisis. ACE inhibitors should be used immediately at the diagnosis of scleroderma renal crisis. SSC patients treated with glucocorticoids should have regular monitoring of blood pressure to detect scleroderma renal crisis. 5. Gastrointestinal involvement. Proton pump inhibitors, PPIs, should be considered for the treatment of scleroderma-related gastric reflux and prevention of esophageal ulcers and strictures. Prokinetic drugs should be considered for symptomatic motility disturbances related to scleroderma. 6. Skin involvement. Methotrexate, mycophenolate mofetil, MMF, and/or rituximab should be considered for the treatment of the skin fibrosis. Tocilizumab may be considered for the treatment of skin fibrosis in patients with early, inflammatory diffuse systemic sclerosis. 7. Musculoskeletal involvement. Methotrexate should be considered for the treatment of musculoskeletal involvement in scleroderma. 8. Interstitial lung disease ILD. Mycophenolate mofetil, cyclophosphamide, or rituximab should be considered for the treatment of scleroderma ILD. Nintedanib should be considered alone or in combination with MMF for the treatment of scleroderma ILD. Tocilizumab should be considered for the treatment of SSc-ILD. High-intensity immunosuppression, usually including cyclophosphamide, followed by autologous hematopoietic stem cell transplantation may be considered for selected patients with early diffuse and poor prognosis, in the absence of advanced cardiorespiratory involvement.
Questions time.
What are the main types of systemic sclerosis?
The main types are limited cutaneous systemic sclerosis, affecting skin distal to the elbows and knees, and diffuse cutaneous systemic sclerosis, which affects the trunk and proximal limbs with early organ involvement.
Question 3. What is the purpose of nailfold capillaroscopy?
Nailfold capillaroscopy is used to assess capillary abnormalities in the nail fold, helping to differentiate between primary and secondary Raynaud's phenomenon.
I hope you found this video informative and valuable for your learning journey.